I am
So sorry. Okay.
okay. So I'm going to, can I get my presentation on here?
Yes, I have enabled the share screen. Yep.
Okay. So here we go. Okay. Okay. Go to. Does that work?
Yep, we can see it.
Okay, excellent. Okay, so so thank you for asking me to be a part of your initiative. I think it's great. I'm always happy to be able to guide anyone that is thinking about a career in medicine. So I will introduce myself. I am Punam Rana. I'm a medical oncologist. I work in Toronto, Canada, and in a community hospital. I think that people can raise their hands if they have any questions as we go along. I would be happy to make this as interactive and as useful as possible. So if you have any questions, please feel free to ask as we go along. So, getting right into it, I'll talk a little bit about my own experience and my sort of journey to medicine. And this slide was a little bit about why, which is, I think, a very important question when you're at the stages of considering a career in medicine. It's really important to think about why is this what you want to do and make sure that it really truly is what you want because it's a long journey. So personally, I had, there's a picture here of a daughter with her father, and that sort of represents the fact that for me, my dad was a family physician and I looked up to him. And so that for sure was an influence in my life and one part of my why. And so I think if you know anyone that's in medicine, it's always nice to be able to reach out and try to have some experiences with them, whether it's clinically or whether it's going to different meetings. It can really give you a lot of exposure and help them make your decision. I also wanted to be in a career where I could work with people. I knew that. So medicine fit that. I have a picture of Terry Fox because he was kind of very inspiring when I was young. And I think subconsciously that must have played a role in why I ended up in oncology. Now, I don't know if you are familiar with Terry Fox, but in Canada, he's very famous and he was pretty young. I don't know, but he may be a teenager when he got sarcoma and he had to have a leg amputation. And to raise money, he ran across the entire country. And so he's a very young sort of cancer hero in our country. And the other thing was I have a picture here of some sort of molecular um, cell. And really, I did enjoy the science aspect of all of the courses that you have to take to get into medical school. And also once you're in medical school, there is quite a lot of science, biology. So it does help if you actually do enjoy that as well. And so now a little bit about what my journey to medicine looked like. So here I'll just speak briefly about my undergraduate background. I'll go into sort of like the schools and universities I was in right after this, but I did a Bachelor of Health Sciences, and during my undergrad experience, I wanted to have research. I wanted to be involved with committees, and I also wanted to do some extracurricular. And I think this is important for a number of reasons. First, what it did was it gave me the exposure, and I think that's important so that you can really truly get the best grasp that is possible to know what is it like to be in medicine, because if you're going to pursue it, you want to make sure you really know what you're getting into. And so doing research experiences was very helpful. I did some in a laboratory in my biology lab, in a biology lab at McMaster University where I went. I literally emailed probably like 50 professors saying, I'm a first year student and I want to volunteer and work with you. And most people didn't get back to me, but really it was kind of like throwing out the net and seeing what I can catch, and then taking what I can. But then I also did some hospital volunteer clinical experiences, which I got through the sort of the technical way you have to apply to be a volunteer, and you have to go through that process, and it's not that difficult. But I also did mass emails to lots of doctors who were doing research, and then I did get some research experiences as well during my undergrad. So that was really helpful because it allowed me to sort of see the research side of medicine as well. I got involved with committees that I thought I was interested in, which was the most important. And also, the Health and Science Society was a great way to learn more about the process of getting into medicine. They would have speakers. I eventually did go on to become the second year representative of that. And I think it does look nice when you're applying to medical school to have some sort of positions on committees where you show that you had initiative and you had responsibilities and you were organizing things. And that always looks good on your resume. I also became president of Amnesty International, and that was really just a passion of mine. And so I think that, and that kind of ties in with the extracurricular, which was dance. I also traveled a lot, and I think that doing things that are really fun it's very important, because undergrad can become a very overwhelming experience, especially when you're striving to really get in the top of your classes so that you can get that GPA to get into medical school, and sort of allocating some time to things that you really truly enjoy will allow you then to have a more enthusiasm and motivation to do all of the other more targeted things to get you in. And now a little bit about medical oncology itself, and what that is, how to become a medical oncologist first. So I did medical school at McMaster University, and I am a Canadian physician, but the program in the United States is quite similar to Canada. So it would look very similar to go into medical oncology. After medical school, I applied to internal medicine, and I did a residency of 3 years there, and I went to the University of Ottawa. I then did another 2 years of residency in medical oncology at the University of Toronto. At that point, I was a medical oncologist. I wrote my exam for the qualification and to be able to practice. But I did pursue further studies, which often does happen in oncology for a number of reasons. One is that it can be difficult to get a job, and so people are quite often doing fellowships to get more qualifications. And my initial path was to pursue a career in academia, in which it's really an assumption that you have to have a fellowship. So I did that fellowship, and then I also did a master's in epidemiology, again, because I thought that it would be a good asset to bring into an academic career as a medical oncologist, as you do a lot of research in academia. So ultimately, I finished all of what I felt was great to do a academic medical oncology role, but then I really had a change of heart, and towards the end of my master's and my fellowship, I realized that for me, I really enjoyed being in the community more than being in an academic center. And so I did then pursue my current job, which is working in a community hospital in Toronto. And so I think that that is not an atypical thing that can happen to doctors in different areas, where you may take some time to figure out exactly what it is that you really feel fits you in terms of your lifestyle, in terms of the way you want to interact with your patients, in terms of the other responsibilities you would like to have in terms of your career, including possible research or administrative roles or teaching. So all of these aspects come into play when you want to decide which career you want to pursue. What exactly is medical oncology? So it is a branch of internal medicine. It is one of the newer branches. It's been around for maybe about 40 years or so. And it deals with the systemic treatment of malignancy. So there can be solid tumors, solid malignancies, such as breast cancer, colon cancer, lung cancer, or malignant hematology, which has to do with lymph nodes and blood, such as lymphoma or myeloma. Some centers, you may find that a medical oncologist would only treat solid tumors, and in some centers, they would treat both solid tumors and malignant hematology. So to do malignant hematology, which is the lymphoma and the myeloma, the other path to get to that career would be to do internal medicine and then do hematology and then go into malignant hematology. Another aspect of medical oncology is that we work very, very closely with our other members of the team. So most cancer patients will have multiple cancer doctors, including the surgical oncologist who will do surgery to remove the tumor, the radiation oncologist who will administer radiation to the tumor, and then the medical oncologist, which is myself, which is the systemic treatment. And by systemic treatment, we really are referring to pills or intravenous, either chemotherapy or other non-chemotherapy treatments. So this is a little history about the history of oncology, actually, and cancer treatments. And you'll see that historically surgery was really the approach, basically just to cut tumors out. And then it was initially, prior to having any medical oncology interventions, it was Mary and Pierre Curie who discovered that X-rays can treat tumors. And so that was introduced into the treatment of cancers. And then it was around the World War II when they found that, incidentally, that some of the gases used in the war were treating lymphomas, and they discovered some chemotherapy agents. And so for a large part of up from the 1940s until about the 1990s, it was a few chemotherapy agents that were used. And it was in the 1980s and 90s where more targeted therapies came into the scene and increased the options of treatment for these patients. And it was more in the 2010s that immunotherapy came into the picture. And we'll talk a little bit more about that. So this is basically what I just discussed, and this is more of a review of what we talked about. So you can see here that there was chemotherapy was really the mainstay until about 1996, when we got a targeted agent, which was a pill. So when we talk about chemotherapy, we're referring to intravenous, IV treatments that kill the cancer. And these targeted agents are actually pills. So it was nice to see that there was some newer medications coming into the picture. And now, more recently, you may have heard about immunotherapy, which is very exciting. And most immunotherapies, as far as I know, are in the cancer treatments given intravenously. And a little bit about immunotherapy, because this is kind of something that people are hearing about immunotherapy is treating cancers, and it is true with immunotherapy. We are seeing results in cancer patients that were unprecedented prior to the immunotherapy coming into the picture. And so it is quite exciting in terms of possibilities of treatment for cancer patients, and also ongoing discoveries that are happening based on this. And so immunotherapy is basically a treatment that will interfere with the tumor and your own immune system. So what happens is a cancer cell can put a brake on your own immune system. And when the cancer cell puts a brake on your immune system, then your immune system can't kill it. So normally your immune system can identify foreign cells and bodies and beings and organisms such as viruses, bacteria, and tumors. And normally your immune system is able to kill them off. But what can happen is that some cancer cells discover a way to block your immune system, and that allows them to continue to grow and grow without being killed. And immunotherapy is very cool because it actually just stops that break that the cancer put in, and it allows the immune system to use its own mechanisms, which it already has in place, to then kill the cancer. So it's very, very cool. A little bit about next generation sequencing, and I'm bringing this up to kind of highlight the fact that that medical oncology is really a very, it's an area that is just exploding in terms of its new research, exciting discoveries, and there really is so much happening right now in medical oncology. And so the next generation sequencing is the technology that's currently coming into the scene, and it involves doing genetic testing on the tumor and looking at different targets that we can different mutations in its RNA that we can then target to try to kill those cells. So it's really quite advanced. It's still very new, and we're still, you know, when I trained, I graduated from oncology in 2010, and this certainly was not something that was being used as a routine, and it really has come into the scene. So we're all learning and growing every year, and that's pretty cool because I know that we're going to continue to have new and exciting things coming up over the next several years, and I'm pretty certain that my career is going to be continuously growing and teaching me lots of exciting new things. So what's a day in the life of a medical oncologist like? So a medical oncologist is not somebody who can just really set up a private practice in, you know, in a building somewhere like many other doctors are able to do, because we really work with a large team. So yeah, having the treatments that we administer, including chemotherapy, immunotherapy, these are quite advanced in terms of getting them made and then storing them and then getting them delivered. And so you really need an amazing team of pharmacists and then oncology nurses, and you need the proper infrastructure to be able to administer the treatment. And so working is really usually in some sort of a clinic where it's an oncology clinic or an oncology hospital, but it really is working with that team. So a lot of the work is just outpatient. Patients come in to your clinic, and then you see them, and then you see how things are going with them. You find out how they're feeling. And then you also look at more subjective assessments such as CT scans, and you can see how their cancer is doing. And then you make decisions about treatment, and then they're able to go and have their treatment sort of in that center. And usually they go home after that. There are some chemotherapies where patients are admitted to hospital, but mostly they're not. But patients, of course, do get sick either as a result of the treatment sometimes, or as a result of their cancer, or sometimes they get sick from a pneumonia and they just happen to be a cancer patient. So a lot of hospitals, such as where I work, we do have a oncology inpatient floor where we take care of our patients when they need to be admitted to hospital. And so we do take turns rotating and being in charge of those inpatients. And so that is also a component of my practice. And being on call is part of that. So being on call for a medical oncologist in my hospital really means that if any of the hospitalists have any questions, then they can ask us and consult us, the medical oncologist, and we will consult those patients, whether it's someone who has a new tumor that needs to be worked up, or whether it's somebody who has a known cancer that's being treated at a different hospital, that's come in with something. We can also manage those patients. Tumor board meetings are also a part of a medical oncologist's sort of weekly routine, and what that involves is it's a meeting that has interdisciplinary physicians involved, including the medical oncologist, the surgical oncologist, radiation oncologist, pathologist, radiologist, and I think I got most of them. And we all sit and we discuss cases that are that require discussion, basically. So there are certain cases that we discuss as a routine, such as rectal cancer patients that have bulky cancers, and then there's others that are just one of the doctors feels it warrants a meeting with the other doctors and we can all discuss it together. And then sometimes we want to have an area where we can discuss, the order in which we may treat a patient, or the way in which we may treat a certain problem that a patient has. And so it's really nice to be able to be in a room together, but now we're often doing it virtually because of the pandemic, but we are able to discuss patients, and so that's it's a really big part of our care, and I think that's a standard thing at all cancer centers. And then also research involvement. So medical oncology is certainly an area where there is a lot of chances to be involved with research, either at an academic center where there's a lot of research happening, but even in a community hospital where I am, we do have a clinical trials department and we do run clinical trials. And so we do have the opportunity to become more involved and become the principal investigator of our site if we wish. And we also have an opportunity to enroll our patients into our trials. But the other thing about medical oncology is that there is often certain patients that are no longer able to tolerate, or they don't have any more standard options, and we want to explore any other options for them. So we may refer them to other centers. Sometimes they go to other places in Toronto, or sometimes they'll even come to the States and look, because there may be a clinical trial that's being run in that center, which will allow them to potentially have access to a drug which otherwise they're not able to get access to. So this is also a component of our care that we always have to keep this in mind. We're always keeping sort of our ties with all of our colleagues, and we are handing patients over when we feel that there's good trials at other centers that would be best in the best interest of our patients. So I will talk about a few cases so you can see what it's like to have patients coming in and what the process is really from a medical oncologist in terms of our role. So this is a case of a 60-year-old female who presents with a large bump on her breast. So the first thing is they would usually present to their family doctor at this point, sometimes the emergency department. But usually the normal course is that the family physician will order a mammogram. along with, and then depending on what they find there, if it's something that looks like it warrants more workup, then they will go ahead and order a biopsy, usually ultrasound guided biopsy. So this patient's biopsy showed that she has what is called invasive ductal carcinoma, which is really the most common type of breast cancer. And clinically, it measured 6 centimeters, and she's got these inflammatory changes on her skin of her breast. And then we also have this information that it's ER positive, PR positive, HER2 negative, and those are details about the tumor, which will allow us to treat them a little bit more targeted. So from her family physician, now she's been found to have a invasive ductal carcinoma of her breast. She's referred to a surgeon. Usually that's the first step that happens from the family physician, but this time the surgeon referred her to the medical oncologist and said that, would you consider this patient for neoadjuvant chemotherapy? So neoadjuvant actually refers to having it done before surgery as opposed to after surgery. So the medical oncologist would recommend neoadjuvant chemotherapy because there's benefits to that, because it can shrink the tumor and make the surgery easier. It will allow us to monitor whether chemotherapy is working, and it will give us information about the patient's prognosis at the time of surgery. So there are these considerations that we have to think about when we want to decide whether we want to recommend whether a patient would benefit from having preoperative or neoadjuvant chemotherapy. So this patient undergoes 4 cycles of chemotherapy of AC, followed by 4 cycles of paclitaxel. And that's very much a standard regimen in breast cancer. And as she was having her chemotherapy, she was seen between every single cycle, and a physical exam was done. And she had presented with a 6 centimeter tumor and a red breast. And the nice thing is that just after 2 cycles of chemotherapy, the redness disappears and the tumor starts to go down to about 5 centimeters. And another cycle later, you can measure that it's now down to 2 centimeters. And sometimes by the end, you can't even feel the tumor anymore. So that's how you know that this chemotherapy is working. The patient then goes ahead for surgery, and she's found to have a little bit of remaining cancer. At that point, the medical oncologist, I would refer her to a radiation oncologist to get an opinion about adjuvant radiation. So adjuvant radiation means that that after she's had her surgery, would there be any benefit to have any further treatment to further reduce her risk of the cancer from coming back? And the radiation doctor would recommend 5 weeks of daily radiation for this patient. And she then takes anti-estrogen treatment for 5 years, which is a pill once a day, to further reduce her risk of breast cancer from coming back. And she takes that because you may remember that she was ER positive, which is estrogen receptor positive. So because she had estrogen receptor was positive, we would give her an anti-estrogen for 5 years. If her estrogen receptor was negative, then we would not be offering this. And then after she has completed her radiation, she goes on to surveillance. So now, instead of having a mammogram every 2 years, like most women in their 60s are recommended, she would have one every year, and she would have breast examination. And there is a recommended guideline for how to do that. So usually in the first 2 years after the diagnosis, we do a breast exam every 3 to 6 months for the first 2 years. And then for years 3 and 4, it's more like 6 to 12 months. And then after year 5, it's usually minimum once a year. So as part of our ongoing surveillance of the patient, we follow these guidelines to do our best to make sure that we would catch anything if it were to come back early on rather than late. So now on to the second case. This is a 70-year-old Caucasian male who has a past medical history of hypertension and gout. His medications are hydrochlorothiazide, ramipril, allopurinol. He has a 15 to 20 pack year history of smoking. He is retired and he's married with no children. So what happened was he went to his family doctor for a routine checkup, and he felt that he was asymptomatic, but he was noted to have a wheezing sound on the right side of his lung. And so a chest x-ray was ordered, and that did show an abnormality in his right lung. So he was then ordered a CT of his chest, and his right upper lobe found in his right upper lobe, he was found to have a 3.6 centimeter speculated mass. In his right hilum, he had a 16 millimeter mass. Right hilum, he had a 16 millimeter node, which is a lymph node. Right paratracheal area, 13 millimeter node, and in the right subcarinal area, 13 millimeter node. So those are lymph nodes. And so he has a biopsy of that right upper lobe mass, and it does show adenocarcinoma. The TTF1 positive napsin A plus, those are things that the pathologist would report, which would confirm that this is a cancer that originated in the lung. And the patient's cancer is EGFR negative and ALK negative, and PD-L1 is 1 to 49%. So these are more details about the cancer that will give us more information on how to treat it. Similar to how the breast cancer patient had an estrogen receptor that we can target. If patients have mutations in EGFR or ALK, then we can target those. And then if they have PD-L1 more than 50%, then we would be able to give them certain treatments with immunotherapy. So this is all information we always have to take and then make our assessment on what would be the best treatment. So with lung cancer, if we don't see that it is immediately metastatic, then the standard staging would also include a PET scan. So when we see a cancer patient, we do have to do staging on them to confirm their stage. And each tumor is different. So a PET scan, for example, is, these are the images from the PET scan. It is a standard for lung cancer and certain other cancers as well. But it's not, for example, for breast cancer. So there's specific guidelines, which is very nice because then we can know what to do. And it's all based on evidence because the studies have been done and have shown that using PET scan for lung cancer is a better way to get a more accurate stage and to find out whether there is in fact any additional lymph nodes or tumor areas that might light up. And that's very important in lung because you really want to know if they have advanced disease before you go in and do some surgery. And with breast cancer, however, the trials using PET scans have not shown that they really added that much information to the staging to make it more accurate. And so therefore it's not routinely recommended. Now that's in Canada. We do really practice evidence-based staging because our patients don't pay for this. It's part of our private healthcare. Things can be different in the United States, possibly where it's not all publicly funded. So there may be more leeway in ordering additional tests, perhaps, which may be covered by insurance companies. So the patient had his staging, which including a bone scan. He had a CT of his head and a PET scan, and then a mediastenoscopy, which is where they take a little camera and they put it into the mediastinum to look at the lymph nodes. And turns out that he has station 4R and station 2R are positive. So he's now diagnosed with stage 3 lung cancer. And he is reviewed at the multidisciplinary cancer conference, the MCC, and the recommendation where the medical oncologist and the radiation oncologist and surgeons all discussed, and they say, we would do concurrent chemoradiation on this patient, which basically means doing chemotherapy and radiation at the same time, as it is the most aggressive approach, which will give the patient the best chance to have no cancer recurrence. After completing that, the patient is then enrolled in a clinical trial where patients such as this complete this standard treatment, but then they're actually randomized into different arms of the trial. So this patient is randomized to receive either durvalumab, which is a immunotherapy, versus placebo. And that is given for 2 years. The patient tolerated it well. They don't know if they're on placebo or durvalumab, but the patient tolerated well, and now this patient continues to be on surveillance. And so after this, the Pacific trial, subsequently, after the patient's been in it and completed it, it's interesting because we often have our patients in trials and then we don't know the results until a few years later. And it's always interesting to see what those results will be and how our patients did. And this particular clinical trial found that by adding 2 years of durvalumab, so immunotherapy, to these patients, significantly increased their life expectancy. And it was then changed and became the standard that patients that have this stage 3 cancer could have immunotherapy after they completed their chemoradiation. Now, a third case to give a different perspective on some of the patients and cases we deal with is a 93-year-old male who's admitted to hospital with falls and anemia. He is found to have a new locally advanced sigmoid cancer. So he undergoes staging scans, which show that he does have metastases, and that puts him at stage 4. And so he is not a surgical candidate. So surgery is not an option. Sometimes it can be for stage 4 cancer patients, but when the cancer is very advanced, it is not an option. And so he's not a surgical candidate. So really his options are for systemic chemotherapy with sigmoid, which is a part of the colon. So with advanced colon cancer, we don't usually use radiation unless it's needed for pain control or some other palliative type of treatment, but it's not usually a treatment used to actually treat the cancer. And so his only option is to have systemic chemotherapy. And this is discussed with him. And he learns about the treatment, the chemotherapy, what the side effects would be, and then also what the benefits would be. So that we weigh the pros and the cons. So there would be a chance to have a prolonged life by depending on which chemotherapy a patient opts for. It can prolong your life for over 2 years. But if you go for the treatment, which is perhaps not as aggressive, which probably would be the case with a 93-year-old, then you may be looking at several months of extension of life. But the issue with these types of treatments is that the patient must be able to be strong enough so that they can come into the cancer clinic and have their regular blood work done and have a checkup done. And between all of the cycles of treatment, to make sure that they are safe to proceed with their next cycle. And so that is a requirement. And so that unfortunately was not something that he wanted to pursue. So he did discuss it with his family, and he makes the decision that he does not want to have chemotherapy. And that's when he is then put onto the a palliative route, where he has a focus on having his symptoms managed rather than the tumor. And the treatment is not going to be to treat the tumor, but the treatment is going to be to treat his symptoms. And so usually in some centers, the medical oncologist may also act as the palliative care physician, but a lot of large cities will have a dedicated palliative care team, which consists of a palliative care physician and nurses who will then take over the care of the patient. And often they can do home visits, which is really nice. And so that's really what happens. So my role in this patient is to really talk to them about their diagnosis, talk to them about their treatment and the pros and the cons, and help them and be there with them when they make that decision on whether or not they want to pursue that or not. So advice for pre-med: as much as possible in undergrad, take the classes that interest you. So there are many classes that are prerequisites to get into medical school. So of course you have to take those. They may not interest you. But aside from those, really, I would advise you to take the ones that do, because I found that I took, those, I don't know if they still call it that, but like bird courses where they're supposed to be easy, but when they're so mundane, it actually takes more energy out of you to write those tests, because you just are so disinterested in it. Whereas when you take courses that motivate you, that activate you, really, they actually give you that energy. So I will never regret taking courses such as Shakespeare and popular culture and religious studies that I thought really kind of helped me make me feel a bit more well-rounded in terms of how I felt. Have an outlet for having fun and creative self-expression again, because same thing. I think that when you have that outlet, then you have a greater capacity to tackle those harder classes and those more challenging and boring tests that you have to do. So I think that making sure you have that balance is really good, not only just to make you feel good, but I really think it allows you to then do better in the rest of your courses as well. I would really question why you want medicine and make sure that you have a good answer for that you're satisfied with, that you really do your best to learn what medicine is, what are the different aspects of it, and then from that, once you know about it, why do you want that? And be curious about the different areas and keep an open mind. So once you do get into medical school, and I'm sure you will, if that's what you really want, then keep an open mind, and you may not know what may really be your the thing that clicks with you the most. It might surprise you. So yeah, just enjoy the process, and that's about it. So does anyone have any questions?
So if anybody has a question, they can put it in the chat or just use their mic to ask any questions. Okay, I'll start off. So, do you have any recommendations for study habits or study methods you used in medical school, or even now, how do you keep up with the latest? Because you also said it's always changing, always new advancements are coming out. So, do you have any advice for staying on top and knowing, learning new things all the time?
So I think that the advice that I have, once you're really in medicine, I think it is very challenging. And so I think initially when I would be on my rotations, I would have this long list of things that I need to look up. And you realize over time that it's just too daunting you're too tired, you're not going to get to it. So when you can, and when the question arises, immediately look it up. on the spot, and avoid having long lists of things that you kind of have to look up. So for me, practicing as a community oncologist, the very challenging part is to doing lots of tumor sites. So when I did my fellowship, I focused on breast cancer, and in the academic centers, those oncologists usually do 1 or 2 sites. And so in a community hospital, you're doing really all the solid tumors. And so I'm constantly having to look stuff up. And so, as soon as I have an opportunity, I will look it up and not wait and save it for at the end of the day, because that will not go down well. And in terms of if anyone is in their undergrad or high school, I would, I wish I had learned about meditation prior to when I actually did. So you'll see here that my Instagram name is The Mindful Mama, because I am sort of pursuing I want to be part of like proliferating and teaching people about all of the benefits of mindfulness, especially in children, because I do have 4 kids now. And I wish I had learned about meditation prior to like when I did, which was just in 2012. So I was pretty much done all my training. That is for me now the single most important thing I do to help me focus. And so that when I am reading or when I am engaged in any activity, I'm able to really be more present. When you're more present, you will retain more. You will be more focused, and your studying will be way more, it will yield a lot more if you do meditate. But I mean, that's in a whole other presentation, right? In terms of how to get into that. But I mean, it's everywhere these days, right? So you can there's so many apps. There's the Insight Timer, there's Calm, Headspace. These apps have so many thousands and thousands of meditations, and you can just put in your subject. I haven't done this, but you may be able to type in help with studying, and there may be meditations that are geared specifically towards that. So I think that would be a really great tool to help you study efficiently.
There are some questions in the chat. Can you see them?
No, but I think I need to stop sharing maybe, yeah?
Okay.
Okay, the chat, there we go. Okay, so the first question, on a scale of 1 to 10, how difficult would you say oncology is? So that is a very good question. And the answer is, so I think for someone who's not a medical oncologist, it would be a 10. And I think for someone who is meant to be a medical oncologist, it would be like, it's not difficult. I think the thing about medicine is that you have to find what suits you. What is the specialty that is best suited for the way you see yourself approaching patients, the way you see yourself treating patients, the way you want to have a practice. Every area of medicine is different. If you're in the wrong area, it's going to be a 10 out of 10 difficulty. So I think that I'm not sure, Ananya, I'm not sure if you meant difficult to actually like get into that specialty. I don't know if that's what you're referring to, like difficulty of getting in. But if you're referring to difficulty of how difficult it is to be a medical oncologist, I mean, for me, I absolutely love it. And so it comes naturally, and therefore it's not difficult. It would be like a 2. Okay, so that being said, I also have to admit that there are very challenging parts to being a medical oncologist. We are talking about life and death and loss and grief all the time, right? And so that part of things is very challenging, but it's very, very rewarding. Does that answer your question? There's another question. Okay. Okay, so when you were talking about the negativity of the test for one of the cases, what does EGFR and ALK mean? Um, okay, so EG, so EGFR and ALK. So those are basically um, those are on the pathway of the of tumor of cell growth. And so though when they are basically transmembrane proteins, and they are used to activate cells to proliferate and grow. And so when there is a mutation in one of those, you could call it structures, then we can, those treatments are their tyrosine kinase inhibitors that can be used to target those mutated pathways. So if it's negative, it means that the mutation is not, there is no mutation in the EGFR pathway, or in the ALK pathway, there is no mutation. So that's why they're saying it's negative. And that means that the treatments that would use to target those would not work. So it's information about the tumor that tells you that you can't use those certain treatments for it. Does that answer your question, Natalie?
Dr. Punam, I had a question.
Yes.
What are some when you first became a medical oncologist, what were some challenges or misconceptions that you had cleared about the profession?
Okay. So challenges about being a medical oncologist. So I think there's always challenges when you're practicing with people that are dealing with illness, right? So there's there's a lot of emotional component um, to your cases, because you are dealing with people who now have cancer. It's the C word, you know? And so I think dealing with the um, the psychosocial support that we give patients and their families is definitely a challenging part of our job, which is probably more so in medical oncology than many of the other areas of medicine. And what's challenging is that we are always having to balance when we see a patient who has for example, stage 4 colon cancer, but it's potentially curable, like a 20% risk that a 20% chance that we can cure it, but an 80% chance that we can't. So it's always challenging to present your patient with a good balance between hope and reality. That's probably one of the most challenging aspects, because you don't want to take away their hope, but you don't also want them to be unrealistic and live in a reality that's not thinking about what all the options are that could be, such as the fact that they may not survive very long. And so that's certainly one of the most challenging things as a medical oncologist. And I think that I think as much as it's challenging, I think that once you learn how to, once you have experience with speaking with people about their disease, with compassion, but also being very honest with them about it, then you realize that they really do appreciate that. And then it becomes an interesting thing, that it becomes actually quite rewarding that you get to have this role in their life where they can trust you and, believe you when you say, okay, no, things are going okay right now, or things are not going so well. And so So I think that a misconception may be that medical oncologist is it's hard to establish that relationship with your patients, but I think actually we get very, very close with our patients and their families. So I don't know if that answered your question, but you can tell me what you think.
Oh yeah, it did. Thank you so much for the insight. I really appreciate it.
No problem. I think there's a question, what do you do if you do not know how to treat a patient? So that's a great question. I think that happens. That's a reality. There's patients that are very complicated. They don't fit like the mold of, stage 2 breast cancer. You do this, so there's definitely patients that don't fit that mold, and you have to think outside of the box. So one is that you could read about any updates that may be published on that particular case. So we're constantly reading as medical oncologists. We're constantly reading journals, and we're constantly reading the guidelines, like the American Society of Clinical Oncology, ASCO, has really good guidelines. The NCCN guidelines are very comprehensive. We have some Canadian guidelines as well. But then we also usually will bring the case to our colleagues and discuss it at multidisciplinary cancer conference, MCC. So that's a nice thing about being in as a medical oncologist. You never feel like you're just kind of thrown out there and have to deal with things on your own. You will always have a lot of support from your colleagues in terms of brainstorming and running cases by them. So are there any ways you deal with the emotional aspects like grief besides meditation? I think talking about your experiences is extremely important. And I learned that when I was training in internal medicine and I was doing my rotation in palliative care, and the palliative care team in Ottawa had this really nice tradition where once a month they would get together and they would actually talk about the patients who had died. And they had kind of not all of them, but many of them would have gotten to know these patients because this was an inpatient service, and just actually kind of giving themselves closure on the death of these patients that they had gotten to know was really therapeutic. And so for me, I am in a very, very tight-knit collegial oncology group, and we talk a lot, actually. And it's not to say that everybody talks to everybody, but myself, I do have a few of my colleagues where we do sort of just like, say, what, this sucks, my young patient is progressing and not doing well, and being able to talk about it is very important. So I think that's how meditation, and then talking about your experiences. And you know what, I know that a lot of doctors have this culture where we don't show emotion and we don't cry, but I'll tell you, medical oncology is not one of those. So medical oncology, you get to know your patients, and there will be tears at times, when you're sitting with your patient. And I think that's human. It allows you have a connection with your patients, but I think you do learn to let yourself feel the emotions, but then just try not to bring it home, and just try to deal with it when it's there and just feel those emotions, but don't bottle them inside. Okay. I think there is another question. I'm from Canada, and I heard it's really, really tough to get into medical school here because the competition is very high. How was the experience for you? I hear that every year it's getting more and more competitive, and I don't even know. I do think that all you can do is just your best, like you can, if you're here and you're listening to this, which shows already that you're the type of person that's taking initiative to learn. And I think that is already going to put you ahead of others who are not doing that. And so I think that the reality is that because I was actually 1 year, I sat on the admissions committee in my medical school at McMaster, and the truth is that the applications are not even looked at if there's not a certain GPA, right? So you can have like the most stellar, well-rounded application, but you do need to make that cutoff. So really making sure that your grades will make that cutoff just so you can have your application even read. I think that's a prerequisite, you know, if that's just number one. And then once you have that GPA, really trying to get yourself well-rounded to show that you're somebody who has been able to manage not just your grades, right? Because medical school is very challenging, and the admissions, they want to choose people that they think are going to be successful in the medical school program. It's very challenging, right? So showing that not only did you get good grades, but you were able to be on certain committees and you volunteered and you also have things you do for fun. That's also very important. I think that will make your application much stronger than just the grades alone. Good luck. Is there any other questions?
Okay, I think that's it for tonight. Again, thank you so much for agreeing and to talk with us and speak with us. I personally learned a lot, and I'm sure everybody who came learned a lot too. And you had amazing advice for us as well. So thank you so much, and I hope you have a wonderful night.
Thank you so much. It was my pleasure. I wish you all very good luck. Take care.
Thank you.
Okay, bye.